Okay, so this is recording. All right, and I don't have a picture of myself or anything here because I don't know, it just feels right not to. All right, so this is Farm Unit 4, Farm 2 Unit 4. Usually I go over all the drug classifications and stuff as well, and the vocabulary. So I'm just going to kind of tailor that down so that we can get through everything. At the end, if we have time to go back over that, we will. I'm going to kind of guide you a little bit about some of this information so that you can highlight or make notes. All right. So do me a favor. Let's try it like this. I'm going to try and prompt you when to make a note. Okay, so that you can concentrate on a specific slide, ask questions. All right. What we're going to be looking over is some endocrine drugs, the classification, the action, the patient teaching, the evaluation, expected outcomes, and side effects. And I can tell you that this bank of questions is pretty big. And then I thought to myself, I need to put in there some of those class cake questions that you've been seeing on your exam on some of the other drugs so that you can kind of get used to answering those questions. So I'm going to try and do that too on Sunday as well. All right. We're going to perform your drug dosage calculation. It's calculated in your pre-exam. It's there. Evaluate lab values for drugs that are related to the endocrine system. And of course, the endocrine system is pretty narrow about what we look at. However, you've got BUN, creatinine, and liver function tests that have been pulled into your pre-exam as well. Identify legal and ethical considerations relating to the endocrine system medication administration. That's always a very wide, broad topic. So there's no way to cover all those possibilities in class, but we do talk about some. Being aware and defining your medical terminology related to the endocrine system medications. I have the vocabulary in here that comes from chapter 17, chapters 18, chapters 9, and chapter 20. And then I went back to the other pre-exams and added 20 to all of them. I've been busy. I went back to your other pre-exams and added vocabulary from chapter 20 to all of those. So the next cohort that gets in there will see those vocabulary words, but you're going to see them now in this unit. But I also went back and added them. And if you went and did any of unit 3, you might have seen some of those come up. So all those vocabularies from all of those units. And then so the endocrine system, we're primarily going to be focusing on a little bit of the pituitary gland, the thyroid, the pancreas, the adrenal glands. The pituitary gland, the thyroid, the parathyroid. I'm sorry, not the parathyroid. Pituitary gland, thyroid, pancreas, and adrenal glands. Those are going to be our concentration. This is the picture of the anatomy. I'm not going to explain that to you. We can understand that a pituitary gland is actually what we refer to as a master gland. And it has the responsibility of excreting follicle-stimulating hormones and luteinizing hormones and antidiuretic hormones, and also thyroid-stimulating hormones. The pituitary gland is that master gland. So just think like this too. If you had a brain injury, what happens to that pituitary gland, the master gland? If it gets damaged, it damages the rest of your body too. Your parathyroid gland is responsible, of course, for the concentration of sodium and calcium in the blood as well as in the urine. And your parathyroid hormone just helps to regulate calcium levels. Your thyroid gland is located in your neck. Your thyroid gland plays a very, very vital role in your metabolism and body functioning. It also has a responsibility of secreting calcitonin, and it helps also to regulate the the calcium in the blood and in the bone. So if your thyroid doesn't function properly, the parathyroid cannot carry on that responsibility. They both work together as a team, as a couple. When the thyroid does not function, its functions are low, we call that hypothyroidism. The thyroid is responsible for metabolism. So if the thyroid doesn't function, what happens to your metabolism? It slows down. That's why Sandra can eat Chick-fil-A every day and not gain a pound, and I eat it or look at it and I gain 20 pounds. I have a slower metabolism thanks to my thyroid, and Sandra doesn't have a thyroid problem. Does that make sense? So not only metabolism, but heat regulation. The thyroid helps to maintain a normal temperature. But when you have hypothyroidism, you have a low temperature. Like 96.4, and you're like, my patient's 96.4. I don't know, do they have hypothyroidism? Because that might be the reason. And you thought they were just old, right?
Oh, is it working?
Well, no, we're kind of rigging it to work.
Oh, I won't, if it's working for you, it's.
That's not really how I wanted it to work. You know, I'm spoiled.
You're kind of a princess.
I am. I want it my way and the way it's supposed to be. Let me unpass. I don't know where she comes from. Check my temperature. Look at me. We'll go right to conference. Would you say short and something? No.
When you do the swords. What's
All right, got it. Thank you. All right, perfect.
Is it the way you want to know?
All right. So hypothyroidism, it helps to regulate temperature. If you have a slow metabolism, do you think you gain weight?
Oh, yeah.
Yeah.
Which
Yeah. And of course, having said that, you have a problem with calcium levels in your body. Because it's not working well. So you're gonna have probably weaker bones, more prone to maybe osteoporosis. Think like this too. If it helps to run your metabolism, would you believe me if I said it also helps to run your circulatory system? So it plays a role because it deposits hormones into the bloodstream. It plays a role in the cardiac and the cardiovascular function. So it kind of helps to set a pace. So if it functions normally, your blood pressure might be like 120/70 and your pulse might be 76. But if you have hypothyroidism, your blood pressure might be 100/60 and your pulse might be 58. Correct the hypothyroidism and your vital signs will go back up to borderline normal, where they should be. Does that make sense? So if you have untreated hypothyroidism, you're going to have bradycardia. You're going to have potentially hypotension. Do you not have that?
I'm sure I'm on the page too.
I know, and that's the reason why I'm kind of elaborating. It's kind of fuzzy, but I'm kind of elaborating. Uh-huh, yeah. So this is about weight gain. Right? This one here is just about confusion, because it's true. The lower functioning that hypothyroidism becomes, level of consciousness changes as well. Why is that? Because it's responsible for dispersing a lot of hormones out into the body, because it coordinates with the pituitary gland. And it lacks that version of hormones throughout the entire body, and it causes a big imbalance. So in some people, it's more pronounced than other people. But here's an example. A woman had gone through a traumatic event and lost a child. And so speaking with her, you give her your condolences, right? And so the woman just is like very flat of fact, and she's looking at you and she's like, thank you. Thank you. And then you walk away. I'm walking away and I'm like, something's not right about that conversation I just had with her. She's not the same person, but she just went through a traumatic event, right? So sometimes stress can bring on hypothyroidism, and that's what had happened. She already had hypothyroidism, but this traumatic event made it worse. And it made it so low, she had to be put in ICU on medication drip to help correct it. And the reason why she knew that she needed hospitalization is because she actually passed out, and she had hypotension, she had bradycardia, and her level of consciousness had significantly been impaired. And it was all because of the imbalance of the hormones. You have, if you have slow metabolism, do you think the person has frequent bowel movements? No. They have constipation. Their skin is dry. They have decreased oil. I don't know if they can hear me when I walk away, so now I'm kind of getting afraid to walk away. So, having said that, would you believe me if I told you patients that have hypothyroidism have depression? The imbalance of the hormones, they have depression. Did you know that they sleep a lot? They have a lack of energy. What's that? Lethargy. Yes. depression, bradycardia, hypotension, constipation, abdominal bloating. They may even have very heavy menstrual cycles because it's responsible for coordinating back to the pituitary gland. So when this doesn't spit out the follicle stimulating hormone or the luteinizing hormone, because it doesn't communicate with the rest of the endocrine organs, such as the gonads or the ovaries. So while the pituitary gland is a main master gland that sends out messages, if the thyroid gland doesn't function, it doesn't send out its messages. And then so you've got a chain ball reaction of dysfunction. And the picture's got a lot of little things in it, but I just wanted to concentrate on those things that I told you. Hypothyroidism is also referred to as myxedema. So this person here that has that rounded looking face, actually it's one of those side effects from having hypothyroidism. And usually it happens when it's gone untreated. It's a characteristic that begins to develop. It's this moon-like looking face. Another, you might have heard, because some patients, they really like disease process diagnosis for themselves. They might say to you, I have Hashimoto's disease. Have you ever heard about that?
No.
This is another name for hypothyroidism, is Hashimoto's.
Oh, yeah. Don't they be having like bulgy eyes when they got the thyroid?
That's a few more slides, and that's another disorder of the thyroid. So don't go there yet, Sandra. Stay here with me. Creatinism. So if a woman is pregnant and she has hypothyroidism, her baby is also affected because in that first trimester, the bloodstream is shared. And in the second trimester, it's partially shared. And then at the end of the second trimester, the baby has its own bloodstream, but in the meantime, it has lacked hormonal growth because of the mother having a lack of those hormones. Does that make sense?
Mm-hmm.
So creatinism, I don't have a picture here, is developmental delayed individuals. So the child's head will be extremely small and they'll be underdeveloped. And so when they're born, they will be disfigured some way, but they will definitely have, and that's an example. Where's your casting? Yeah, there you go. There's a little kid there with creatinism.
They have the bulgy stomach.
Sometimes it just depends. Children, when they're born, they don't have any abdominal muscle strength, so they always have a tendency to have bulging abdomens. What's that?
Like their spine is like not developed either, just gives them that.
Well, and that's spina bifida, and that actually is related to other congenital problems. Hang on a second, I have to do a stop share, so that's an interruption. That is me. That's what I said too, is like, who's that? She washed her hair today. Oh my gosh. Okay. Okay. So let's just, it says there's just 4 things open. It won't let me reposition that. We can't do that anymore because it just Okay, so now it's back. All right, here we go from current slide. All right. So when a woman has hypothyroidism, because of what the child could potentially experience is developmental delay, they don't want that child to experience that. So they want the woman to take a replacement therapy. It's called a hormone replacement therapy, the medicine that we're going to be talking about. The woman needs to take it the entire pregnancy. So while we're getting ready to talk about the medications that are actually for the thyroid disorder, let's just talk about some of those lab values. You should be able to refer back to your lab values. Bring that up. So you see here that we have a thyroid function. So we have a T3. So this is part of measuring the functioning of the thyroid. They'll look at the T3 and the T4, but only after they look at the TSH first. First, they look to see how bad the thyroid stimulating hormone is. They want to know how much the thyroid is not functioning. Once they understand that, then they want to do a T3 and a T4 to understand the severity of the problem. They'll also do a parathyroid hormone because I told you that those two are kind of partners. The parathyroid hormone sits right underneath the thyroid, but in front of the thyroid. So they always want to make sure that that parathyroid functions too. And usually it does. In rare instances, does it not? So those are the labs that we're going to be concentrating on. Okay, so it should be back onto this. So when your lab levels are low, it's actually going to indicate that there is some hypothyroidism. So when we start looking at the medication that treats hypothyroidism, it's referred to in your book as a thyroid hormone agonist. Mm-hmm. It's actually, what page you say it was?
It's on 314.
314.
It was 17.2.
It should be. Yeah, it should be there on your drug classification chart. So here you see it as hormone replacement therapy, also known as HRT. All right. The class that your book identifies it to be is thyroid hormone agonist. So it actually, this medicine actually mimics the effect of what thyroid hormones T3 and T4 do, and they do help to regulate metabolism, but not just metabolism. It also helps to regulate the temperature, the weight, the bowels, because that's part of the metabolism, body temperature, blood pressure, pulse, The sad thing is that levothyroxine is one of these drugs. The other drug you might see is Cytomel. So these drugs are primarily given like in the morning. First thing in the morning, before the patient takes any other medicine, before they eat. So in long-term care, these patients are usually prescribed this at 6 o'clock in the morning. Now, do they work if they're given with food and other meds? Sure. They just don't work as effectively. Does that make sense? And we're dependent on these meds to help change the lab values back to normal. So because we're monitoring these medications through the blood work, we really need to give the meds on an empty stomach so that they have the best benefit for the patient. Does that make sense? Because it would be sad to think that we increase the medicine unnecessarily because the patient's taking these meds with food and such. Now, can you what? 30 minutes. Yeah, 30 minutes. Patients sometimes are really looped into over-the-counter opportunities that are so much cheaper that they are not required to go do blood work for, and they're super cheap. So they may want to purchase some homeopathic remedy meds out there that might help their thyroid, right? So I just kind of put this up here as an example. I can go to Peru and walk up to the pharmacy and tell them the exact dose that I need of levothyroxine, and they'll give it to me. But they'll ask me, do I have a health problem? And I'll tell them, yes, I have hypothyroidism. And then they'll give me whatever supply I want. Now, if I go up there and I ask for a large amount, they're not going to give it to me. But they'll give me, I say I'm from the States, I'm visiting and I'm out of medicine. And so they'll give me some. I don't have to have a prescription. I don't have to have proof. Right? There's different regulations in different countries. So sometimes, even though that price looks very steep, sometimes it's very cheap in other countries. And I can tell you, I don't pay too much for it when I get it. It's pretty economical. Remember what I said this medicine does? It takes your bradycardia and it changes it to hopefully normal pulse. But if you get too much of this medicine, what do you think it could do? Yeah, it can make your heart rate tachycardia instead of normal, because giving this medicine to a patient that has hypothyroidism, you're increasing metabolism, you're increasing the pulse, you're increasing the blood pressure, you're increasing the thyroid supplement in your body because it's absent, right? So a lot of things can happen. They could speed up and maybe lose a few pounds in their metabolism. They could speed up and have more frequent bowel movements instead of constipation. They could develop oily skin. Their temperature could go from 96.4 to 97.8. It can make a big difference in a lot of things. We have to monitor the lab values with this medicine because patients can dangerously get too much. And if that's the case, they'll go into tachycardia. They'll go into hypertension. They'll go into chest pain, palpitations. They could actually have a cardiac arrest from too much medicine. Do you realize that? What's that? Yeah, you can put that under side effects. And we have another slide here. Now, patients have to take this for life. You probably have some patients that have mild hypothyroidism and they refuse to take the medicine, but their symptoms are mild. They haven't progressed. Once these symptoms continue to progress, this medicine, their body is going to be very dependent upon. So it's for life. We have to teach the patient, don't increase your medicine. Guess what? This medicine has a very long half-life of 14 days. So once you take the last dose, the medicine lasts in your body from that last dose for 14 days. And only half of it goes away in 14 days. The other half still remains behind. Therefore, because we take this medicine once a day, but the half-life is very long, it does take a long time for it to get into the system. It takes about 14 days before it starts getting into the system and making changes. It takes about 6 to 8 weeks before it really makes a difference in the lab value. So when a patient starts taking this, they expect that immediate fix. You know, they're not going to be tired. My pulse is going to be a little bit faster. My blood pressure will be better. I won't be constipated. My skin won't be dry. My hair won't fall out. But it's a very, very slow process. Very slow. The whole time your patient's taking this, we want to get to the end point, which is they go from hypothyroidism to normal thyroid function, that those lab values are normal. They're within those parameters. And so it looks like they don't have hypothyroidism. Take the medicine away and they will. Is that making sense? All right. So we're only taking the medicine to correct the problem. Take the medicine away, the problem comes back. It's not a cure. It's just helping to balance out the medical problem. Now, we're constantly evaluating this patient every time we give it. Because if I check a patient's heart rate and blood pressure before I give a med, such as this one, and the heart rate's 100, this medicine is going to make the heart rate go up even more. Because that's what it's doing. That's the med that it is. It's supplementing and giving more hormones. So if the heart rate's already at 100, then they're getting too much of this medicine. And you would not want to give any more of this medicine if that's the case. Does that make a sense? Does that make sense? The patient has a diagnosis of hypothyroidism. They're taking levothyroxine every day. They've been taking it for 2 years every day. You go to them this morning, their pulse is 100. Do not give them this dose of levothyroxine that they've been taking every day for 2 years, because you're going to cause that heart rate to go above 100. And that's tachycardia, and that's when a cardiac arrest can happen. So, you know, it's so easy to just like gently go in and be like, hey, Jane, how are you today? And count this pulse for like 15 seconds, multiply it by 4, and give her the med. And guess what? She doesn't even know what I've done. It's that easy. It's that quick. And it's just super simple. It took me 15 seconds to know if I need to give it or not. Does that make sense? Without even looking at a lab value. Now, if the heart rate was 100 and I calculated it that way, I'm going to hold the med. I'm going to call the doctor and say, can we do a TSH, a T3, T4? And let's look at the PTH too, because I need to hold the med because the heart rate's 100 and I'm not sure what's wrong. Is it the thyroid medicine or is there something else? Are you with me? Levothyroxine, also known as Synthroid. And the other med too is lithronine, which is known as Cytomel. I don't see that one too often. Levothyroxine is the primary one. It has become a cheaper drug than it used to be. It used to be very expensive, but now that it's been out on the market for so many years, it's super cheap. If the patient who is taking Synthroid says, I'm feeling some chest pain, because that's what angina is, right? I'm feeling some chest pain, then you should ask yourself, are you getting too much thyroid medicine? Because that would cause chest pain, angina, because it's speeding up the metabolism, speeding up the cardiovascular system. The patient may end up with heart failure from that, because the thyroid is getting too much supplement, and it's causing the cardiovascular system to work harder, and it could cause the patient to go in heart failure. It could produce seizure activity too. Don't know, but it's a possibility. Now, if your patient starts doing the weight loss, having the tachycardia, having insomnia, you need to start looking at the labs. Hold the synthroid, look at the labs, make sure they're fine. And then if they're not, get the doctor involved, of course, to change the dose because it'll have to be decreased.
So would the doctor want you to look at the labs before you contact her?
Well, you'll call him, he'll order the labs, you'll look at them, and then you'll call him and let him know what they are, right? And if they're elevated, you're going to make a priority to call him, right? Because we have to do something. There's the half-life of the drug is 14 days, right? So we're going to be fighting the problem for a while. It's not just going to happen today, right? Who knows? He might say, let's start a beta blocker. And that's going to help protect the patient and their heart. Mhm. Really? She refuses treatment. Because of the bulging eyes? You're going to be like, you have hypothyroidism and you don't know it. So look at this. This is a patient that has the thyroid is functioning like way too much. It's functioning way too much. It's producing so many hormones, spitting them out there, getting it into the bloodstream. And guess what's going to happen? Everything is going to start speeding up, right? They're like Sandra. She just eats Chick-fil-A every day and never gains a pound, right? They just start burning calories. They become very thin looking. And they have a high pulse rate, tachycardia. Their blood pressure's up a little bit. They can't sleep at night. They have insomnia. They may even have an absence of a period or menstruation may be absent. They may have really oily skin. They may have anxiety. And the problem is their heart's beating really hard. You know what's going to kind of happen, right? The heart's going to get wore out a little bit. It could potentially lead into heart failure. Hypertension could lead into where? Cardiac arrest, stroke, loss of vision. I mean, there's a lot of things that can happen here. So we don't want the patient to go into hyperthyroidism. So we go back and we start looking at the PTH, the TSH, the T3, the T4. We're going to find those elevated lab values.
So when you take that, all those things, like I stop bulging.
So depending on how severe this has gotten, it can't fix what's broke. It can only help slow down the process and maybe reverse a little bit, but some of this is going to be predominantly remaining.
Yeah, my son's grandmother, she passed, but her eyes stayed like look like this. Like they were really just
My sister, she had,
out of here.
but this is when we were like in her 20s, when she was diagnosed with Graves' disease, but her eyes didn't bulge, but she lost so much weight, she dropped down to like 90 pounds. But now she's very, she don't, you look at her, you couldn't see it.
Right, because it was caught in early stages and managed and continued to be treated. But for somebody who doesn't have it in early stage treatment and they just let it go because they like the weight loss. I mean, a woman who doesn't like the weight loss, come on. If I started losing a bunch of weight, I'd be like, yeah, I don't know what I'm doing, but it's going to continue. Right? What did you say?
She looked like a dope face.
There, it was this past school year. My husband went to school and because you know he works at Jennings and the school was in lockdown because there was this man that broke the window that led into my husband's classroom got into my husband's classroom and put his school jacket on. It was white, said Jennings. And I might even still have the video of it, but anyway, some other students had caught some stuff on video. The guy evidently had crawled up on the desk and went to sleep. So when the police came, it caused him to scatter out. He went through the window, then he came in, and he's standing out there and he's got this really weird behavior. And this guy's videotaping. He's like, look at that man, he's on some dog food. But he was very frail. I mean, oh my gosh. My husband's like, can you wash my jacket like 20 times? Sterilize it.
I would just wait till he put a jacket on and went to sleep on the bed.
Wrapped himself in the American flag and went to sleep on my husband's desk. What's that? I guess so, because nobody was in the school during the night, so they just came in the morning and found it there at 6. Right. But it's just so funny because when the recording was sent to me, I was like, he's on dog food. What does that mean? I didn't know that was slang terminology. So you didn't know it. You do now. All right. So a patient that has hyperthyroidism, has hypertension, frequent stools, insomnia, weight loss, anxiety, they could be disoriented. The level of consciousness can change too. They may act like they have ADHD. There's a lot of things that can happen. Here's kind of an idea again. This is a better picture than the one for hypothyroidism of what it actually, the organ, what it actually affects. Because the patient is wasting away a lot of their nutrition, they could potentially have muscle problems too. So that's why it talks about muscle aches. What do you give a patient that has